Welcome all to the today's class. We start with our code Master MRCOG with concept oriented clarity. We continue with our endocrinology module, and today we are going to discuss about the thyroid hormone, very important from the examination point of view. Okay, so in the thyroid hormones, first we'll talk about the iodine metabolism. So certain SBA questions can be asked from this particular topic. So please listen carefully. So daily requirement of iodine is around 150 to 200 microgram per day. Total body iodine is around 25 to 30 milligram. 80% of iodine is present and stored in the thyroid. Plasma iodine level is around 5 to 10 microgram per deciliter. And what are the sources of iodine? Mainly the drinking water, fish, cereals, vegetables. And commonly used is the iodine salt. That is the most important public health measure for prevention of goiter and thyroid disorders. Okay, so there is a goitrogenic belt, especially in the Indian scenario. It is a Himalayan region. Okay, these are the low iodine areas. Then what are the goitrogens? So these goitrogens are the substances such as thiocyanate, which are present in the cabbage and tapioca. So there is a decrease in iodine uptake because of the thiocyanate. Okay, then thiourea present in mustard, and it causes decreased iodination. And then others such as cassava, millet, maize, they decrease the iodine utilization. Okay, so only function of iodine is a formation of T3 and T4. Okay, so that is the only function of the iodine. Now, here it is actually a 10-step process from the iodine or the iodide to the formation of this T3 and T4. Okay, so we will see all this subsequently. Okay, so this first is a uptake of the iodine that is stimulated by TSH. That is the trapping of the iodine takes place, and it is inhibited by thiocyanate and perchlorate. Okay, so always remember uh, which is the inhibiting factor also. That also you remember, because certain drugs which we use, especially in hyperthyroidism, we should know where they are acting. Okay, so iodine uptake, it is the trapping of the iodine in the thyroid, and that is stimulated by the TSH, and it is inhibited by the thiocyanate and perchlorate. The next step is an oxidation, where iodide is converted into active iodine. An enzyme which is responsible is a thyroperoxidase, that is TPO. It requires H2O2, which is an NADPH dependent. Okay, and it is inhibited by methimazole and thiouracil. Okay, so these are the drugs which are used in the management of hyperthyroidism. So it is at oxidation level these drugs are acting, and conversion to the active iodine from iodide, that is inhibited. Okay, the enzyme responsible is a TPO enzyme, that is thyroperoxidase. Okay, and this is an NADPH dependent step. Next is a iodination. So first what we have seen is a oxidation. Now it is the iodination, that is the organification. So on thyroglobulin TGB, it forms MIT and DIT, that is monoiodotyrosine, and second is a diiodotyrosine. So these are formed, MIT is formed and DITs are formed. So next step is a coupling. So what happens in coupling? So two DITs will combine to form T4, and one MIT plus one DIT will form the T3. And that is the 99% of the hormone is present in T4 format. So DIT plus DIT is will form T4. So this is the fourth stage, that is the coupling. So first is the uptake of the iodine. Second is the activation or the active form of this oxidation, where iodide is converted into active iodine. Then this binds with TGB. Along with TGB, this will be DIT will be formed, and these two DITs will combine to form T4, and MIT plus DIT will form the T3. Okay, but 99% of the hormone will be T4 only. Okay, so 99% of the hormone is a T4 maximum. Okay, and this is stored in the colloid. Okay, so after that, step 5 is the storage, that is stored as a colloid. Okay, thyroid only endocrine gland which stores the hormone. So this is the only endocrine gland which store the hormone. Okay, the next step is an uptake. Okay, that is a pinocytosis. So TGB is taken into the follicular cells. So from here, so whatever these steps have happened here, they have happened in the acinar space, okay, up to the level of the storage. Okay, so initially in the thyroid cell, it is the active form conversion, but after the active form conversion, the coupling and all those mechanism and formation of the T4 will happen in the acinar spaces. From the acinar spaces, again in the thyroid cell, what will happen? It is the uptake, okay, pinocytosis. The process involved is a pinocytosis. So TGB taken into the follicular cells, then there is a proteolysis. Okay, T4 is released from the TGB and it is stimulated by TSH and inhibited by the iodine. So in the this particular follicular cells, this proteolysis happens and the T4 will be released from the TGB because it is bound to the TGB, thyroid binding globulin, and then it is released from this TGB. It is stimulated by the TSH and inhibited by the iodide. Okay, that is the potassium iodide which is used in the hyperthyroidism. So this potassium iodide will act at this proteolysis stage. Okay, while we have seen methimazole and the thiouracil, they are acting at which stage? They are acting at oxidation stage. Okay, so we should know these particular steps and where exactly the drugs are acting, that also we should know. Okay, so from here, once there is a proteolysis, T4 will be released. Then from here it will be released into the bloodstream. That is the step 8, that is the release. So T4 will be released into the bloodstream. Okay, T3 is formed by the peripheral deiodinization. So maximum in the thyroid what you get gland is a T4, but peripheral deiodination will form the T3. Okay, so next is a iodine salvage. So MIT and DIT will be deionated and the iodine is reused. Okay, so this is the step 9, and last is a transport. Okay, so it is along with the TBG, T4 is bound around 80%. It is bound. Then another is a transthyrein that also has got a moderate binding capacity, and albumin which has got the low affinity. So it is bound to the protein, mainly TBG. Then other is a transthyretin and another is an albumin. Okay, so maximum binding is seen with the TBG only. Okay, so only free form is active. So what happens? The thyroid hormone is present in the blood in the bound form, but the active form is only the free hormone. Okay, so whatever will be free, that will only be the active form. So next step is a catabolism. So T4 half-life is around 4 to 7 days. T3 half-life is only 1 day. T4 is converted into T3, which is an active form, and the reverse T3 is the inactive form. Okay, so you should remember trapping is the iodine trapping defect. Uh, so high iodine is required. So if there is a trapping defect, so what you require is a high iodine. Second, oxidation, that is a TPO defect. Okay, so treatment is a T4. If there is a defect step at the coupling level, it is the coupling is defective. Again, T4 will be the treatment of choice. And deiodinase, that is the iodine loss in the urine. Then iodine we need to supplement. Okay, so these are the things which you should remember. Then mechanism of action. So T3 will bind with the nuclear receptor. We have seen the mechanism of action of hormones last session. Okay, so T3 will bind with the nuclear receptor. The hormone receptor complex will be formed. It will enter into the it will bind with the DNA, that is TRE, and it will cause further transcription. Okay, so metabolic effects of thyroid hormones in general, it acts on all cells. Major effect is a thermogenesis or calorigenic effect what you get with this thyroid. So BMR will be increased. There is an increased synthesis. Then there is a catabolism. Okay, at higher dose, at lower dose, there is a synthesis. Okay, for protein, you get both the things, increased synthesis as well as catabolism. So increased synthesis will happen at lower dose. At higher dose, there will be catabolism. Then carbohydrate, there is increased gluconeogenesis, increased absorption. For fat, there is increased lipolysis and decreased cholesterol. And on weight, it is reduced in the hyperthyroidism. Okay. So from examination point of view, decreased cholesterol is seen in hyperthyroidism. Increased cholesterol is seen in the hypothyroidism. Okay. Thermogenesis via uncoupling, oxidative phosphorylation. Okay. So there is a thermogenesis that is one of the major role of these thyroid hormones. Okay. Now coming to the thyroid function test. Okay. How to interpret? When in hyperthyroidism, what is going to happen? T3 will be increased, T4 will be increased, and TSH will be reduced. Then primary hypothyroidism, where T3 will also be reduced, but the TSH will be increased, and secondary hypothyroidism, in which T3 will be reduced and TSH will also be reduced. Okay, that is the secondary hypothyroidism. Okay, so free T3 and T4, that is the most accurate for diagnosis. It is not affected by binding proteins. So it is better. So you have total T3, T4, and you have free T3, T4. So when you want to measure, it is always better to measure free T3, T4 because that is most accurate. Okay. So binding protein such as TBG. Okay. In pregnancy, what happens? TBGs are increased. In nephrotic syndrome, TBGs are reduced. Okay. Then there is a FT4 index, that is free thyroid hormone index. In hyperthyroidism, FT4 index is increased. In hypothyroidism, FT4 index is reduced. Pregnancy, it is normal. Then TSH is the most sensitive test, and that is the best screening test for any thyroid disorder. Okay. Then other tests such as TRH stimulation test, we don't use commonly this, but normally when you give TRH, this TRH, what will happen? The response will be increased TSH. So on TRH stimulation, normally you get an increased TSH. What happens in hyperthyroidism? On TRH stimulation, there will not be any response. In hypopituitarism also, there will be no response. But if it is a primary hypothyroidism, then the response will be exaggerated. Okay. Then coming to the cholesterol. Cholesterol hypothyroidism, it is increased. In hyperthyroidism, it is reduced. Okay. Radioactive iodine uptake. Also, it has got a diagnostic value. However, it is contraindicated in the pregnancy. Then there are certain thyroid antibodies, such as in Graves' disease, you see these long-acting thyroid stimulant antibodies. Then Hashimoto's, there are anti-TPO and anti-TG antibodies. Okay, these in Graves, these are thyroid stimulating antibodies. Okay, so hyperthyroidism. What are the features and what are the causes? In hyperthyroidism, causes are the Graves' disease, toxic nodular goiter, and pituitary when the TSH is excess. Okay. In lab findings, there will be T3 and T4 will be increased and TSH will be reduced. Okay. So most of the time it is the pituitary cause. So TSH will be increased and that is why T3 and T4 will be increased. Okay. In hypothyroidism, what happens? There may be primary hypothyroidism or there may be secondary hypothyroidism. In primary hypothyroidism, T3 will be reduced, T3, T4 will be reduced, but the TSH will be increased. However, if it is a secondary hypothyroidism, then both T3, T4 as well as TSH will be reduced. Okay. And what will be the TRH response? In primary hypothyroidism, it will be exaggerated response, while in secondary hypothyroidism, TRH response will be absent. Okay. Then key features will be increased cholesterol and decreased metabolism. That is what is the feature of hypothyroidism. Okay. Now coming to the hyperthyroidism. What happens in hyperthyroidism? Mechanism is an increased binding protein. There is a increased affinity of the binding protein. Then there are autoantibodies, TSH secreting tumors, and T4 toxicosis. That is the increased T4 level, and there is a decreased T3 levels. Okay, so these are the mechanism by which this hyperthyroidism will be presenting. Then what are the types? It may be primary hyperthyroidism. That is the thyroid gland is the main cause. That is the primary hyperthyroidism. Okay, so Graves' disease is the most common, and other causes are toxic multinodular goiter, toxic adenoma, functioning metastatic carcinoma, then TSH receptor mutation, struma ovarian, that is ovarian teratoma sometimes can have this thyroid tissue and it will give hyperthyroidism features. Okay, then there may be excess iodine. So these are the causes of primary hyperthyroidism, out of which commonest will be the Graves' disease, and it is an autoimmune condition where you will get thyroid antibodies. Okay, we have seen LATS antibody just now. Then there can be secondary hyperthyroidism. Okay, where there is a TSH secreting pituitary adenoma, or there can be thyroid hormone resistance or SCG secreting tumors, or gestational thyrotoxicosis. These are the central causes when you get a secondary hyperthyroidism. Okay, so common causes will be the Graves' disease, toxic goiter, excess intake of thyroid hormones, and rarely TSH secreting pituitary tumor. Okay, clinically there will be a hypermetabolic state. There will be weight loss, heat intolerance, sweating, tachycardia, anxiety, emotional disturbances, tremors will be there, and GIT there will be diarrhea. Okay, so lab findings in primary hyperthyroidism, T3, T4 will be increased and TSH will be reduced, while in secondary hyperthyroidism, both T3, T4 as well as TSH will be increased. Okay, so from examination point of view, please remember TSH low, it is a primary hyperthyroidism. If TSH is high, it is a pituitary cause which is responsible, and T4 toxicosis, T4 is increased while T3 may be normal or may be low. Now coming to the hypothyroidism. Okay, so it may be primary hypothyroidism or it may be secondary hypothyroidism. In primary hypothyroidism, generally cause could be autoimmune, that is Hashimoto's thyroiditis, then thyroidectomy, radiation, drugs such as lithium, anti-thyroid drugs, para-aminosalicylic acid, etc. Okay, so these are the causes of primary hypothyroidism. Then congenital hypothyroidism, iodine deficiency, absent ectopic thyroid, dysharmonogenesis. Second is a TSH receptor mutation. So that will lead to the congenital hypothyroidism. Causes will be iodine deficiency or absent or ectopic thyroid, then dysharmonogenesis and TSH receptor mutation. Now coming to the secondary hypothyroidism. So secondary hypothyroidism, it will be mainly central causes responsible. It may be pituitary cause or it may be hypothalamic cause. So in pituitary causes, there may be tumor, surgery, irradiation or infiltration or the Sheehan syndrome. Okay, and there can be isolated TSH deficiency. These are the pituitary related causes. Okay, as far as obstetrics and gynecology is concerned, we should remember Sheehan syndrome. Okay, there are hypothalamic causes such as tumors, trauma, and infiltration. Clinically, there will be lethargy, sluggishness, slow responses, and metabolic features such as cold intolerance, weight gain, severe features such as bradycardia, and skin will be dry and coarse skin. Okay, so special conditions such as cretinism, which is seen in children, it will present as a mental retardation, growth retardation, and early treatment is essential. It prevents the irreversible damage, because if it is not treated, it will lead to the irreversible damage. Okay, so lab findings in primary hypothyroidism, we have already seen T3, T4 will be reduced, TSH will be increased. While in secondary hypothyroidism, both T3, T4 is also reduced and TSH will also be reduced. Then TRH response in primary hypothyroidism, it is exaggerated, while in secondary hypothyroidism, there is no response. Okay. So from examination point of view, most common is a primary, that is autoimmune. Second, it is more common in women than men, and there is an increased cholesterol level in hypothyroidism, and myxedema is seen in adults, while in children you get a cretinism. Okay, so sometimes you can have a euthyroid goiter. Okay, cause is an iodine deficiency. Mechanism is that there is a decreased thyroid hormone, so increased TSH level, and there is a thyroid hyperplasia which leads to the goiter. Okay, so lab findings will be T3, T4 will be low normal and TSH will be increased. Okay, so goiter with normal hormone level is a euthyroid goiter. Okay, now non-thyroidal illness, okay, also called as sick euthyroid syndrome. Okay, so the features of this non-thyroidal illness or the sick euthyroid syndrome, it is seen in acutely ill patients where there is a decreased T3, T4, and TSH, also called as sick euthyroid. Okay, so most important is do not assess thyroid function during the acute illness. So this is what is you should remember. So we should not assess the thyroid function in the acute illness. Okay. So from examination point of view, few things to remember. One, Graves' disease. Okay, it has got thyroid stimulating antibodies, TSI antibodies stimulate TSH receptors. Then there is a primary hyperthyroidism, that is increased T3 and T4 levels, and there is a decreased TSH. In secondary hyperthyroidism, all will be increased. In Hashimoto, that is a hypothyroidism, it is an autoimmune hypothyroidism. Primary hypothyroidism, increased TSH level. Secondary hypothyroidism, there is a decreased TSH level. Okay. Cretinism, it is irreversible if not treated early. Euthyroid goiter, there is increased TSH, however, normal T3 and T4. Sick euthyroid, all will be low and lab will be misleading. Okay. So TPO inhibitors are methimazole and propylthiouracil. This is the thyroid is the only gland which stores the hormone. Then T3 is more active. T4 is a pro hormone. While in the gland, what you get more T4, but peripherally T3 is more active. Okay, free hormone is the active hormone. TSH is the best screening test. In pregnancy, there is an increased TBG, but normal free T4 level. Graves' disease, you get a TSI antibody which stimulates the TSH receptor. Hashimoto's is an autoimmune destruction leading to hypothyroidism, and radioactive iodine uptake is contraindicated in pregnancy. Okay, so that finishes the thyroid hormone. And we have few questions. Doctor, please go through these questions.
Yes, sir. A drug inhibits thyroid peroxidase activity. Which step of thyroid hormone synthesis is primarily affected? Iodine uptake, sir. Option B, oxidation of iodine.
Okay, so drug inhibits thyroid peroxidase activity. So this is the oxidation of iodine. That is the step which will be inhibited. So thyroid peroxidase TPO catalyzes oxidation of iodide to active iodine and iodination. Anti-thyroid drugs such as methimazole and propylthiouracil will inhibit these particular steps. Next.
Which of the following substances inhibits iodine uptake by the thyroid gland? Iodine uptake by the thyroid. Methimazole, thiocyanate, thyroxine, iodine, propranolol. Sir, option B, thiocyanate.
Yes, that also we have seen at uptake stage, it is a thiocyanate that acts. Okay, so thiocyanate competes with iodine at transporter level and inhibits the iodine trapping. Okay, next.
A patient has defective coupling of iodine tyronase residues. What is the most appropriate treatment? Anti-thyroid drugs, high iodine diet, T4 replacement, TSH administration, surgery, defects. Sir, high iodine diet. Option B.
There is a coupling, defective coupling. So if the coupling is defective, what is going to be important? We need to supplement T4. Okay, because even if you give iodine, ultimately it has to go through the further steps.
Okay, yes, yes. Yes.
Okay, so you will be going for T4 replacement. Okay, so coupling defect prevents T3 and T4 transformation. So you will have to give T3 with exogenous T4, treatment with the exogenous T4. Okay, next.
Which step of thyroid hormone synthesis makes the thyroid gland unique among endocrine glands? Iodine uptake, oxidation, storage of hormone, release of hormone, transport in blood. Sir, option C, storage of hormone.
Correct. So this is the only gland which causes storage of the hormone. Okay,
Which of the
next.
following is the which of the following is the major circulating thyroid hormone? Sir, option B, T4.
So circulating is mainly T4 hormone. Okay, 99% of the thyroid hormone is produced as a T4, which acts as a prohormone. Okay, next.
Which enzyme is responsible for peripheral conversion of T4 to T3? Sir, option B, deiodinase.
Deiodinase. Okay, so it is the peripherally and most active is a T3 only. Okay, so from T4 you get T3 by the action of deiodinase. Okay, it is a selenium dependent active form of thyroid hormone. Next.
Which thyroid hormone has the greatest biological activity? Sir, option B, T3.
Yes, biological activity is more with T3. Okay, T3 is more potent while T4 acts mainly as a prohormone. Okay, next.
A pregnant woman has increased total T4 but normal free T3. Increased total T4 but normal free T4. What is the explanation? Increased TSH, increased thyroid binding globulin, increased T3 uptake, decreased albumin, increased metabolism. Sir, option B, increased thyroid binding globulin.
So in pregnancy, TBGs are increased. Okay, so
Yes.
estrogen increases the thyroxine binding globulin. There is an increase total T4, but free norm T4 is normal. Next.
Which of the following is the most sensitive test for thyroid dysfunction? Sir, TSH, option D.
Correct. Most sensitive is the TSH. Okay.
Yes.
TSH is the most sensitive screening test for thyroid dysfunction. Next.
A patient has low T3, low T4, and low TSH as well. What is the most likely diagnosis? Primary hypothyroidism, secondary hypothyroidism, hypothyroidism, Graves' disease, euthyroid goiter. Sir, option B, secondary hypothyroidism.
In secondary hypothyroidism, what is going to happen? T3, T4, TSH all will be reduced. Okay, so that is the secondary hypothyroidism. Low TSH, low T3, T4. So the cause is central, that is pituitary or hypothalamic cause. Okay, next.
Which of the following is the characteristic laboratory finding in primary hypothyroidism? Sir, low TSH, a high option C, a high TSH.
Primary hypothyroidism, there will be high TSH. Okay, and T3, T4 will be reduced. Okay. So high TSH. So loss of feedback leading to increased TSH in primary hypothyroidism. Next.
A patient with hyperthyroidism shows no increase in TSH after TRH administration. What is the explanation? Pituitary failure, hypothalamic failure, negative feedback from high T4, increased TBG, increased iodine. So, no increase in TSH after pituitary failure, option A.
A patient with hyperthyroidism shows no increase in TSH after TRH administration. So what is the explanation? So the patient is a case of hyperthyroidism. Okay. And there is no response to TRH. Okay. So is it the pituitary failure? There is a already hyperthyroidism, no? So negative feedback from high T4. So she is a case of hyperthyroidism. So this high T4 level will inhibit both at pituitary by negative feedback mechanism. Okay. So that is going to be the, so high thyroid hormone will suppress TSH. So TRH will fail to stimulate TSH. Okay.
Okay.
Next.
Which condition is associated with elevated cholesterol levels? Hyperthyroidism, hypothyroidism, Graves' disease, T4 toxicosis, thyroid storm. Sir, hypothyroidism.
Yes,
Option B.
hypothyroidism. Option B, correct. Hypothyroidism. So decreased thyroid hormone, there is a decreased cholesterol metabolism, and there is an increased cholesterol level. Okay, so metabolism is reduced. So yes.
Which antibody is most characteristics of Graves' disease? Sir, option C, TSI LADs.
Okay, these are long-acting antibodies. Thyroid stimulant antibodies. Okay, correct. So thyroid stimulating immunoglobulin, TSI, activates TSH receptor, leading to hyperthyroidism. Okay, these questions are important from examination point of view. Next.
Yes. Which thyroid disorder is most commonly associated with autoimmune destruction? Which thyroid disorder is most commonly associated with autoimmune destruction? Sir, option C, Hashimoto thyroiditis.
So which thyroid disorder is most commonly associated with uh, autoimmune destruction? Right, Hashimoto's thyroiditis. Okay, autoimmune destruction will lead to hypothyroidism. Next.
A patient with goiter has normal T3 and T4 but elevated TSH level. What is the most likely diagnosis? Normal T3, T4 but elevated TSH. What is the most likely? Hyperthyroidism? No. Secondary hypothyroidism? No. Euthyroid goiter? Graves' disease? Thyroid carcinoma? Sir, euthyroid goiter. Option
Yes,
C.
it is going to be euthyroid goiter because T3, T4 is normal, but TSH is increased. Okay, so this happens in iodine deficiency. TSH levels are increased, that will lead to the goiter, but hormones remain normal. Okay, next.
A patient admitted with severe illness shows low T3, low T4, and low TSH. What is the best next step? Start thyroxine, start anti-thyroid, start perform radioactive iodine test, repeat testing after recovery, perform biopsy. Sir, option D, repeat the testing after recovery.
Yes, we have to repeat the testing after recovery. Okay, because non-thyroid illness or sick euthyroid, that is the misleading labs. Okay, so we have to reassess. The ideally the patient is euthyroid, but Because of the sickness, the lab reports are abnormal. Okay, next.
Which of the following conditions is associated with elevated TSH, T3, and T4? Primary, all are elevated. Okay. Sir, option B, secondary hyperthyroidism.
Which of the following condition is associated with elevated TSH, T3 and T4?
Option B,
So
secondary hyperthyroidism.
secondary hyperthyroidism. What will be there in the secondary hyperthyroidism? Yes, it will be TSH will be increased, T3 and T4 will also be increased. Okay. So from examination point of view, TPO inhibitors are the methimazole and PTU. Thyroid is the only gland which stores the hormone. T3 is more active while T4 is a pro-hormone. TSH is the best screening test. In pregnancy, TBGs are increased. So total T4 is increased. In Graves' disease, there are TSI antibodies. Okay, then Hashimoto's, there is an autoimmune destruction and sick euthyroid. All the levels, that is T3, T4, TSH are low, but it does not require treatment. You have to repeat the test. Okay, so this finishes our thyroid hormone.